Myself, my co-chairperson Dr. B.N. Gupta, may I request him to take the chair. Convener Dr. Parvez Alam, are you there, Dr. Parvez? Co-convener Dr. John Sarkar. Moderator Dr. Sujita Mitra. Sujita was coming, where is come? Okay, so the speakers for this session, Dr. Pratik Nishant, Dr. Vishal Agrawal, Dr. Patnaik Sabyasachi, was there? Dr. Jatinder Singh Wala, yes, I think, Dr. Gopal Pillai, Dr. Jatinder Wali. So at present, I think Dr. Jatinder and both Jatinders are available. Yeah, present.
Also here. He's just gone out, I think.
Who?
Sabyasachi?
Sabyasachi, I think, just gone, we'll call him. So, I think...
because Dr. Sabyasachi's presentation I have seen, he uploaded.
Okay.
but
he will be coming.
He will be coming. So now we'll go to Dr. Jatinder Singh Bhala. He will start. So each talk is 7 minutes. Okay, please.
Morning everyone, the topic I am going to cover is can we better perfect biometry. In earlier times, cataract was removed first and spectacle prescription given last. But today we calculate the power of IOL first and the cataract surgery is done afterwards. So IOL calculation plays a very important role to determine refractive outcome after the surgery. And since 75, IOL power has been basically calculated using only two parameters, keratometry and axial length. But today, we can customize the power of IOL to achieve near plano result even in highly refractive eyes. There are group of patients who value their emetropia so much when you break news to them that they require spectacles after cataract surgery, they are extremely disappointed. And what are the major sources of prediction error for IOL power calculation? ELP prediction 35.5%, followed by axial length measurement and keratometry measurement. Few subjects in the field of ophthalmology are as complex as IOL power formulas because it depends on with the help of mathematicians, and we ophthalmologists are not very fond of mathematics. There were hurdles in accurate estimation of effective lens position because older formulas worked on some assumptions. That is, the shorter eyes and flatter K eyes were supposed to have shallow AC and shorter effective lens position in contrast to longer eyes and steeper K eyes. But Holiday taught us that there are 9 types of eyes. Eyes with normal anterior segment, 80% may have short axial length and 90% may have longer axial length. And similarly, in patient with normal axial length, 2% may have the varied anterior chamber depth on either side of the spectrum. So relationship between anterior segment size and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formula is bound to fall in shorter and longer eyes. Is it so bad to just keeping using the old formulas? Yes, because with that only 1% of the surgeons achieve more than 92% accuracy within plus minus 0.5 diopters. This was Rayner Medal lecture given by Warren Hill. They said if you start using newer formula, that this percentage improves to 91% of eyes within 0.5 diopter of the target refraction is achievable. I'll straight away jump to the newer formulas like Hoffer H5, Ladas Olsen, Barrett 2K, Barrett Universal and Hill RBF. Prediction theory says more the number of variables, more accurately you can predict the outcome. So we have jumped from 2 variables to more variables. We have 5 variables in Barrett Universal and 7 variables in Holiday 2 formula. And we also have the use of artificial intelligence and ray tracing in Oculus and Phaco optics. And there were some other assumptions also that we always assumed that there is fixed ratio of anterior and posterior corneal curvature. Cornea was treated as a thin lens with uniform refractive index of 1.3375 and actually it is 1.37. And so this gave us good result in average eyes but not in atypical eyes. So there were some constants used to emetropize and achieve emetropic results, and this was A constant in SRKT, A0, A1, A2 in Haigis, personalized anterior chamber depth in Hoffer Q and Holiday 2, and Holiday 1 had surgeon factor and Barrett has lens factor. But mind you, what are these lens constants? These were typically developed during later stages of regulatory process when plano convex lenses were used and contact ultrasound biometry was used. But now we have shifted away from contact ultrasound biometry and the lenses are no longer plano-convex. So optimization of lens constant is required. Either you can do yourself depending on your results, or you can use various sites like software, Biometer, IOL Master, or Hagee's ULIP website. Surgeon who does not personalize his A constants, they repeatedly have errors which are more than 0.5 diopters in almost all their results. So if you start optimizing your A constant, you will see on the left side, your results within 0.5 diopter improve from 18% to 70%, and within 1 diopter they improve from 50% to almost 95%. Let's talk about the newer formulas like Barrett Universal 2. Here we use lens factor, which is influenced by not one but 4 factors like keratometry, axial length, anterior chamber depth, lens thickness, and white to white measurements. Hill RBF depends not only on artificial intelligence but also on pattern recognition. Olsen formula uses ray tracing and thick lens concentration to predict effective lens position, and LADAS is very intelligent. It combines the best performing portions of multiple 3rd and 4th generation IOL calculation formulas. Kane is a newer formula which, besides the factors taken in the Barrett Universal 2, also takes into account central corneal curvature and gender of the patient to make its predictions. EVO 2.0 formula is also a new formula which is giving us very good results now. Intraoperative aberrometry, although it came with a bang, but it is valuable only as a confirmatory or complementary test, and it is not going to make lens calculations obsolete in the near futures. Ray tracing gives us true geometrical effective lens position and is incorporated in Oculix and Allsense, but there are limitations of ray tracing. That is, it is not outperforming the standard 3rd generation formula, so there is no reason to switch to the ray tracing formula. Hill RBF formula not only gives us the accuracy level, it also gives us this thing whether your result is inbound or out of bound, depending on whether the database has the enough data paralleling your specific case. So if we compare Barrett and Hill RBF, both are current, both are more sophisticated, and although they use, I'll just take a minute, sir. Although they use completely different theories, but they give results which are within 0.25 diopter of each other. So what should I do? Should I use multiple formulas? Koch says yes, use multiple formulas. But Holliday and Barrett says use specific formulas for specific condition and don't average your results. So these are the newer instruments. So what is the best way to deal with short eyes? Traditionally, we were using Hoffer Q, but now the literature says use Barrett and Hill RBF. So conventional wisdom has been overtaken by smart wisdom. And this was the meta-analysis done in shorter eyes, and they found that Kane, Barrett, and EVO are giving us better results. These are the literature from 2021 and 22. And in longer eyes, what should be done is, again, what they have shown is EVO 2.0, Kane, Barrett, and Hill RBF are outperforming, and these newer formulas you don't have to buy, they are available on the sites. And this is the meta-analysis which has been done in longer eyes, shorter eyes, and you find that Kane, EVO, VRF, Barrett, Hill RBF, and Pearl DGS are the formulas. So we no longer talk about the Holliday, Hoffer Qs, and Hagee's, and the newer formulas have clearly taken. So these are the steps you can take to maximize the likelihood, optimize your lens constants, validate your measurements. Yeah. So this is how take measurements yourself. Don't remove yourself from the process and become totally dependent on your optometrist. Spend extra time counseling patients after refractive surgery. So 90% within 0.5 diopter is achievable. Why we are not able to go beyond 90% is because the precision limit is 0.25 diopter for keratometry, axial length 0.1 millimeter, anterior chamber 0.2 millimeter. So we are not able to go because the least count of these, we are not able to cross them. So can we use single formula for all eyes? Yes, if you don't have access to other formulas, start using Barrett Universal 2 and Hill RBF. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. 80% was acceptable, but now 90% now is achievable. So smartness is learning not only from your own, but also from others' mistakes. Let us not only become experienced, but also smart. So to fully enjoy this Validation, use validated measurements, optimize your lens constants, and adapt to newer technologies. And for that, the present level of accuracy which we have achieved, we are grateful to all these ladies and gentlemen like Holiday, Wang, Koch, Warren Hill, Thomas Olsen, and Barrett. Thank you everyone for your kind and patient time.
Thank you, Dr. Bhalla, it's really a matter of concern for all the surgeons that in spite of using so many formulas in ifs and buts, many a times you land up in surprises. So I wish we should have just used one formula which would have applied in all cases. But anyway, thank you very much for your nice presentation. So next, I will invite Dr. Pratik Nishant. He will be talking on making the most out of your post-graduation and residency. Pratik.
Good morning, everyone. Esteemed chair, my teachers, members of the audience. So this is a presentation which I am mainly directing towards the young generation and the postgraduates, making the most of post-graduation and residency, my 7 golden rules. First rule is choose your workplace wisely. And this wise decision should be based on the status of the compulsory bond, the faculty of the department, resources, research opportunities, industry exposure, as well as the language, working hours, food, remuneration that might be significant for some, and the number of attempts at the entrance examinations or the interviews that are there. What I would like to emphasize is it is not wrong to engage with another institution if necessary and if possible in parallel wherever rules allow. The second golden rule is keep alive an active approach. You have to actively catch the best of rounds in classes, prepare properly before the clinical discussions, read about the cases seen in OPD, discuss with peers and seniors, stay abreast with the latest developments and research in the subspecialty of your interest, and experiment with the available resources. For example, you can practice suturing using your own instruments under your microscope whenever the time allows. My third golden rule is learn from all sources. You have to have a global outlook with local relevance. So you have to incorporate all sources into your gamut from which you have to draw important information. So first of all, choose manageable standard textbooks recommended for postgraduates and residents. You can read package inserts of all medications and consumables that are opened in the operating room or in your OPD. For example, you have cyanoacrylate glue, which is not properly written in your textbook. So you can take a package insert and go through it, and you'll get some insights about what a cyanoacrylate glue behaves like when it comes in contact with the tissues. Attend conferences and teaching programs whenever and wherever possible. So whenever is very important, and wherever. Wherever possible. So wherever possible, I'd like to tell you that I had a knack for conferences, and I used to travel long distances to attend physical conferences. So I was an MD student in AIIMS Rishikesh, and I used to attend conferences in the, I've been to Delhi, I've been to Indore, I've been to Varanasi, been to Kolkata also for conferences. And you have to have a broad approach, because the teaching is not limited to your institution or to your surroundings. You can attend surgical skill transfer courses and diagnostic skill transfer courses to iron out any deficiencies that you might find in your routine work, whether surgical or diagnostic. And you have to interact and network with people, be it your peers, be it your seniors, be it your teachers, so that you can gain the best from them. The fourth important point, use technology to your advantage. I would recommend an iPad, no financial interests, to store and annotate ebooks, take notes, view online surgical and teaching videos, prepare teaching learning content, practice drawing ophthalmic diagrams, learning through augmented reality apps, and you can even practice surgery through some apps that are available for free on the App Store. The second important thing is a good camera phone with a net connection which works in your hospital zone. You can capture clinical images, download and transfer online content, view 3D virtual reality surgery which is now available on YouTube. You can store important contacts. You can use social media, but it has to be used wisely. And most importantly, you can make calls. I would recommend to keep a charged power bank and a charger at all times during residency. Fifth golden rule, take care of yourself. Relax at the slightest opportunity. You can video call or talk with your family. Eat well. You can keep reserve food in your bag and don't miss meals. Invest in your health. Encourage yourself adequately and reward yourself handsomely. My sixth golden rule, respect your seniors and your colleagues. Choose your mentors intelligently. Identify your support structure. Seek help from the correct people whenever required. Draw a line for your personal space beforehand and exceed the line infrequently. And again, you have to learn from everyone. Learn the best practices, but also you have to learn, and probably more importantly, learn what not to do. My seventh golden rule, accept learning to be a lifelong process. You are your own toughest competitor. This is said by Dr. Uday Devgan, who is one of the most prolific ophthalmologists of the world as of today. Criticize your activities harshly. You have to aim for betterment at every step. You have to take inspiration from every failure, find encouragement in every venture, and seek blessings from every quarter. So in summary, my 7 golden rules: choose your workplace wisely, keep alive an active approach, learn from all sources, use technology to your advantage, take care of yourself, respect your seniors and colleagues, and accept learning to be a lifelong process. Thank you.
Very good, excellent. I think no youngsters are there to take your advice, but however, it's really wonderful advice to the postgraduates. I wish
The target audience would have been here.
Sir, actually, we are very fortunate that AIOS has given the provision of recording and transmitting the proceedings of the conference. Because now, whenever the links are available, I would eagerly share this to my postgraduates, and I appeal to all of you to share this to more young people.
Why don't you give it to us? We'll pass it on to our students.
Yeah, sure, sir. I'll do that, sir. I'll do that, sir.
Really,
Definitely, sir.
These are the wonderful things you have told.
Very elaborately touched all the aspects, all the points. Which,
Yeah, every postgraduate has to learn this thing. Now, yeah, yours next.
or Dr. Bali will
Thank you, sir. At the outset, I want to thank the chair. I want to thank the organizers. I want to thank AIOS, the LOC, the scientific committee for giving me this opportunity to talk to you about publication misconduct. I have no financial disclosures to make for this particular presentation. Now, you see, publication misconduct is an entire spectrum. Like we have mild, moderate, severe. So we have, it could be a small error, it could be something bigger like a misconduct, or it could be something as huge as a fraud. So there are two concepts to it. First, of course, is research misconduct, and allied to it is publication misconduct. So research misconduct is the fabrication, falsification, plagiarism in proposing, performing, reviewing research, and in reporting the research results. It does not include any honest difference of opinion, or and whenever we are talking of research ethics and publication ethics, there are several organizations that are talked of. The first amongst, the more foremost amongst them happens to be the COPE, or the Committee on Publication Ethics, which was a body which came up in 1997 in the United Kingdom. And now it has about 14,000 members across the world, has a paid membership, And it was started by Michael Farthing way back at the turn of the millennium, and now Dan Culp is running it. It has given us different guidelines and codes which are used very widely. In addition to it, there are other organizations which are working in this field. Now, in addition to all these, which are all these aspects of it, I will draw your attention to the last one, which is inappropriate behavior in relation to misconduct. Now, that includes misconduct. If you one is you've done the misconduct, and second is you've become aware of it, you know of the misconduct, and you don't react to it. Even that is misconduct. That is in scientific terms. And when you add redundant and duplicate publication to it, the lack of declaration of competing results, and the failure of transparency, then that completes the gamut of publication misconducts. So what are broadly the different types of misconducts? We'll just go into it very shortly. Briefly, plagiarism is, you use other people's material, and that is, that could be their ideas, their processes, the results, not exactly in their own words, but you've misappropriated them and you've not given them any credit for it being theirs. It could even be your own writing and, copying from one into another article, or it could be self-plagiarism where your own published work you've copied from there, and in your subsequent publications you've used that. Then of course we have mosaic and accidental plagiarism, which is where we end up quoting it without putting it in those quotation marks, and we forget to put the citations, or we miscite. That means we say something which the author has not actually said. Then we come to fabrication. Fabrication is, you've done nothing, you just create results out of thin air using figments of imagination. And lesser than that is falsification. That means you've done some work, you've got your results, and then you very euphemistically rationalize your results. That's a very euphemistic term which is used in some institutions, and it's not very uncommon. Then of course we have these authorship conflicts. Theoretically, anybody who has contributed intellectually to a paper should be acknowledged as an author, and it should be specified what his contribution to the paper was. But it is not very uncommon to find ghost authors who have written and whose name is not there, who have not been acknowledged, or there may be guest authors, or there may be gift authorships. That means they've done nothing in it, and their names are there. It's not very uncommon. What are acknowledgements for? A person who has contributed to your paper, but it is not adequate to qualify for being an author, then you should always put that in acknowledgements, and always ensure that the work done, what component was done by whom, is actually addressed. The other types, of course, is redundant, where a paper which was similar to something, to the same paper, has been published by the same author, and we do not declare the source, and duplicate publication, simultaneous duplicate publication. Then of course we have salami slicing to enhance the number of publications, where you divide the data sets and put it in different papers. Imalas is the opposite of it, where already published manuscript is taken, and from you add more numbers to it, more cases to it, and you publish it again. Now, what are the reasons why this happens? One is, of course, the pressure for publication. We've said your promotions are going to be linked to it. There is financial enticement, then wish for a massive CV very quickly, and the competition among colleagues. But the main purpose of discussing it here is lack of awareness is also one of the reasons why it happens. We should be aware that these are the aspects of it, and we should avoid them at all costs. Why should we avoid them is because there are direct costs to the researcher and there are indirect costs to the society. So, of course, you can see on this side you can see that these are the direct costs to the researcher. Happens sometimes, sometimes doesn't happen. Your academic achievement may be taken away, there may be loss of fund, time, reputation. But indirectly, what it does is, it destroys the interests, the trust that the people have, that the public has on research that is done. I won't go into the details of it, but there have been 2 or 3 major studies where the results had to be retracted, sometimes after 7 years, once after 12 years, and that actually destroyed the public trust on those institutions. I'm done, sir. Thank you so much, sir. I'm open for any comments.
Is it very common, public misconduct is very common?
Sir, there have been, I think, 4 major publications which have come across, like 4 major meta-analysis.
Yeah.
And in different fields, the highest quoted is in 70s.
Yes.
Percents.
Yeah.
So, and that includes using wrong tools, wrong tests, wrong observations. So, if the observations are right, maybe, a wrong tool has been used, that should be an error, not a misconduct. But, all said and done, what we do is we just make a master chart and we give it to the statistician, and whatever he does is what we come back and we publish. So, it is not that the intention was there. In many of them, it is just that, it has crept into the process.
See, actually, I remember, I think around 10, 15 years back, there was very much hue and cry over some cases in our AIOS also. So those people just, they copied and they published in their own name. These days, I think, due to accessibility to the materials and contents far and wide, so I think they just, they are not very, like previous years, they have got access.
Definitely, sir. It has definitely improved in over the last. But I was the member secretary of our ethics committee,
Nowadays
and
also, the guidelines are very strict, and the journal editors, etc., they're very strict about this. So definitely there's a lot of peer reviews going on. So what do you think, Dr. Malika, your comments on this publication misconduct? It's a very good discussion, I would say. Yeah.
she's a very prolific peer reviewer, actually.
I know.
Yeah.
That's why I'm asking you. Can you give the mic, please?
A mic to the lady, please. Actually, I was surprised. I had the student who comes over. He says it's like the steps of research, and while talking of the steps of research, he says, and then there is after master chart, there's rationalization of results. I said, what is that? He says, no, it is a valid. Then we went back to the speciality from which he had come, because I come from a multi-speciality hospital. So this was an orthopedist, and we found that this was what was happening, and the students actually thought that rationalization of results was one of the steps of the research process.
Only thing I can say is it's more easy to detect plagiarism nowadays, because you can just copy paste on the internet and see where it comes from. You'll often find that even the statements have not been changed, even the words have not been changed.
True.
So it's easier to pick it up nowadays. That's what I can say.
That's what I was telling, that now the incidence is also less, because it's, you have got sufficient material, to access.
So, but I would, a word of caution here, because we are using that Turnitin report. The problem with the Turnitin report is, it's not a blanket thing. A few days ago, maybe just 4 or 5 days ago, I got a paper which said, 7% similarity index. And out of which, 4% similarity was because the drugs used, the name of the drugs, it said this is plagiarism. See, he cannot change the composition of the drugs that have been used. So basically, it is a 3% similarity which gets bumped up to 7%.
Sabyasachi, I think he can give his opinion.
It's a different thing, but as Madam said, plagiarism.
Please, give me the mic, please.
Actually, that helps a lot. Even if writers also, if you put it in that software, doing that, you copy paste things and put that shows the source where you have copied.
Yeah, that's the good thing about it.
That's a good
Yeah.
thing about it. So you can know that these are the lines. And another advantage in now publishing is there is paraphrasing software also available. You put that sentence and that software will change that sentence. So things are becoming easier also. You don't have to paraphrase Microsoft Word. If you purchase that 365, Microsoft 365, there is option for paraphrasing also.
That does
Suppose
it.
you put it in plagiarism software, knew that this is quoted directly from that text, then you put that in this, you will change that sentence and give you 5 options to decide.
Sir, if you talk of,
Everything
there
is
are
made easier now.
yeah, sir, there's in fact open AI, there's something called Rabbit AI. So that goes even one step further. It creates the thing, yeah.
No, what I am talking about is, this is about writing.
Yeah, Rabbit AI does the writing part.
If you want to copy everything, then that is certainly a misconduct. But many times we are not very comfortable in writing because we have stopped writing since long. We may not pick up the right word or any substitute. So this helps. But
So-
if you put the number of cases the same, methodology same, conclusion same, this is definitely to be dealt with very strictly by the Editors Guild.
And so the result, especially in the discussions, like sometimes what happens is the way it is interpreted and written by us, it sometimes ends up changing the meaning of the author. So I would still prefer that, whatever you're picking up from that author, you should try to, keep it close to what, because sometimes the problem is now people from across the world are writing and the interpretation of the same English language is different in different countries. So unfortunately, that's one part.
There is an old proverb in Hindi, tu dal dal mai paat paat. So whatever changes are being done, the people are able to
Yeah,
manage.
obviously, so somebody is ahead of you.
Thank you. Thank you, Dr. Bali. So now, may I invite Dr.
So, respected chairpersons and dear friends, so I am going to speak on the new technology that is coming up in information sector, that is the 5G network that has been inaugurated recently from our state, and ultimately we are going to have 5G telecommunication. What is 5G? It is not moving. Hello. So 5G is 5th generation of wireless broadband network. So previously we have 2G, 3G, 4G wireless network, and we have also fiber optic broadband network. So advantage of this mobile network is this is portable, and this 5G promises unparalleled bandwidth, high speed, reduced latency, reliability and access with data protection facilities. So 5G is incorporated into conventional macrocellular network with overlay of small cell networks. So there will be ultimately plenty of mobile towers, small towers of course, not bigger 4G towers throughout, so that we will get high speed internet services. So now it has started its applications by self-driving cars, which are autonomous, intelligent. There is constant transmission of data also for safety and navigation of those vehicles. Augmented reality is a possibility where the real world can be enhanced. And these applications in our field is to increase the field of vision where it is restricted, particularly in glaucoma and RP patients. Virtual reality also can be possible, where this helps in teaching and surgical training to our ophthalmologist, future ophthalmologist. Without using patients also, they can be taught how to do cataract surgery, phaco or retina surgery, and internet services will be very fast. So what are the challenges facing healthcare services? Why it is required in our system is we have to provide universal, equitable, sustainable eye care to the entire population of world or India. So there are limited resources in terms of manpower, technology. So we have to adopt different approaches like change in screening, diagnosis and monitoring of disease, accurate profiling of disease progression and personalized treatment. So teleophthalmology is a field in which can be enhanced with 5G network. There can be development of digital virtual clinics, so patient will not have to come to the clinic by staying at a remote place, can be also examined and consulted. Virtual reality and augmented reality can be used for the patient's benefit. Artificial intelligence, machine learning and deep learning are also the things that is coming up to diagnose and to screen patients. Internet of medical things where different equipments can be connected and telesurgery is also possible. So remotely operated slit lamp, fundus camera, even remotely performed lasers, PRP, have also started. There can be remote screening. Then with virtual reality, as I have already discussed, ICI surgical simulation system has developed for PACO training and microvis touch for VR surgery. Artificial intelligence can be used with mobile phones to triage patients and to screen out. Then deep learning, in which machines can decide many things, seeing the fundus photograph and OCT pictures, detect diabetic retinopathy, DME, glaucoma, ARMD, ROP, all image-based pictures can be analyzed and diagnosed. So it will be able to predict systemic cardiovascular risk factors from fundus picture also. Telesurgery is a possibility. So from a remote surgeon can do surgery at a very remote place using these technologies. So all the medical related things can be interconnected. So if you have a high pulse rate suddenly or high blood pressure, so that will be detected by your watch and the message will be sent to the hospital concerned where you have registered, and ultimately that hospital will detect that to the ambulance available, just like our Ola or Uber vehicle, and that will come to your doorstep to pick you up because you have suddenly developed some problem in your body that was detected by machines. So these are the possibilities that we are going to have. Still there are limitations. The equipments will be definitely costly. Privacy and security issues are not well known. 5G waves may suffer losses in penetration and attenuation, may not be practical in every population regions, and we do not know the health related issues the electromagnetic radiations can cause. So with these limitations, there is a possibility that we will have our practice of ophthalmology in a much different way in which we are accustomed to. So we may during our lifetime see a different type of ophthalmic practice that we started with. From that we started with. Thank you very much, sir. Thank you.
So Dr. Sabyasachi, should we all practice, start thinking of early retirement from surgery?
No, not exactly.
Jokes apart, I just wanted to have an idea. You're talking of surgery. I'll just switch off. It's not such a big one. Anyway, so we're talking of surgery, right? And robotic surgery as well. So is there a difference between telesurgery and robotic surgery? Because robotic surgery is already there, right? So the telesurgery, is it a little bit different?
No, it's not different, but with 5G things will be very fast and the latent period will not be there. So that was this.
That's the speed of the surgery.
That is the speed of communication.
Robotic surgery, telesurgery are different. Robotic surgery in the same center you are doing, but telesurgery will be doing from some other source. Surgeon sitting somewhere else, he will be in the UK, he will do surgery in India.
Yeah, but then that is again, we don't need to retire. It will be done by us, right?
No, not at all. He will be guiding you. He will be doing. No, not guiding. He will be doing everything.
He will be doing everything.
Robot is doing. Robot is yours. He is sitting there. You are not. You are just watching.
No, the problem with present 4G robotic surgery is the command is there at a distant place. There is a latency. So somebody has to be there to take care where the surgery is being performed practically. Now the problem is this has happened. The surgeon there wanted something to be stopped, but he didn't stop.
So that somebody has to.
It didn't stop because, no, that could not be done. The surgeon who was there, he didn't know that this has to be done. So there was a disastrous surgery. That's why that has not been popular now. So with 5G, they say that there is absolutely no latency, so that the person doing surgery there remotely can decide and can change at every step.
Every step.
So the present day robotic surgery has this deficiency. Here also there has to be a trained surgeon with the patient, so that the command will be given by telephone or something. Has to receive.
Yes.
He cannot manipulate it from there
And
because
next-
there is a latent period.
Next 5 years, you will be seeing more. 6G will come.
No.
Still it will become, yeah.
The definite technology will come.
The speed, basically 5G or 4G is the technology and the
Speed,
speed
yeah.
which will be used.
So,
So
Very nice presentation because it's enlightening, so what's going to happen?
it's the future. It's the future. No? So,
I mean, it's a
I think any other speaker.